Hi, my name is Ida. This is Jenna. And in this video, we'll be covering airway management. Effective airway management is one of the most important skills an anesthesia provider has. The primary goals during airway management are maintenance of oxygenation and ventilation. This requires thoughtful planning and effective preparation. It is important for every anesthesia provider to master the appropriate decision-making strategies and methods to not only manage routine airways, but also difficult airways. In this video, we will start by reviewing relevant anatomy and airway assessment, and then talk about equipment, monitoring, positioning, and various airway management techniques.
The larynx is the part of the respiratory tract between the pharynx and the trachea. It begins with the epiglottis and extends to the cricoid cartilage. It not only facilitates respiration, but also facilitates speech and protects the lower airway from aspiration. It is comprised mainly of cartilages and ligaments. The three paired cartilages are the arytenoids, corniculate, and cuneiform cartilages. The three unpaired cartilages are the cricoid, thyroid, and epiglottis. The cricoid cartilage is the only cartilage that covers the circumference of the trachea, which is why it can be pushed on to occlude the esophagus during a rapid sequence induction to avoid regurgitation of gastric contents. The epiglottis, which is superior to the cricoid cartilage, is an important landmark for direct laryngoscopy. The epiglottis is located at the base of the tongue and encapsulates the glottis to form a lid over it, protecting the larynx from the aspiration of gastric contents. At the base of the tongue, anterior to the epiglottis, is a pocket of cartilage known as the vallecula. The vallecula is an equally important landmark as certain types of direct laryngoscopy blades, such as the curved or Macintosh blade, are inserted there in order to manipulate the area to improve visualization of the vocal cords. A full patient interview and airway assessment must be done before all anesthetics,
including general anesthesia with an endotracheal tube or LMA, regional anesthesia, and IV sedation.
This should be conducted in a thorough and systematic fashion to determine potential problems with bag mask ventilation, direct laryngoscopy, supraglottic airway ventilation, and cricothyrotomy airway placement. After identifying the correct patient and asking about their health history, you can proceed with the airway assessment. A proper airway assessment consists of 4 parts: the dental exam, pharyngeal exam, mandibular space exam, and the neck exam. The dental exam starts with examining for loose, missing, chipped teeth, or large central incisors. You should look at the side of the patient's face to identify an overbite, which would signify difficulty. You should also have the patient perform an upper lip bite test to make sure that they can bite their upper lip with their lower teeth. Finally, assess if the patient has adequate mouth opening. Next is the pharyngeal exam. You need to assess the Mallampati score and the presence of an arched palate. For the mandibular space exam, check the thyromental distance. If it is less than 6 centimeters, this indicates possible airway difficulty.
You also need to assess the compliance of the space behind the mandible. Stiffness indicates difficulty here.
The neck exam looks at neck length and circumference. A short neck or a neck circumference of greater than 43 centimeters indicates difficulty. You also need to assess their neck range of motion. If it is limited, this could cause problems with positioning for bag mask ventilation and direct laryngoscopy. Once the airway assessment is complete, you should check to make sure you have all the equipment you need and that it is functional. If you are doing a general anesthetic, you will need equipment such as a self-inflating resuscitation bag, a suction setup, various sizes of oral and nasal airways, various laryngoscope blades and handles, various sizes of endotracheal tubes, stylets, various laryngeal mask airways, water-based lubricant, nasal cannula and oxygen face masks, and emergency airway equipment. Keep in mind that general anesthesia with an endotracheal tube is the backup plan for all other anesthetics, and you should always be prepared to convert to this if necessary. Once the equipment is set up and your machine is ready, you can bring the patient into the operating room. Before attempting bag mask ventilation or laryngoscopy, the anesthesia provider must first properly position the patient. Here, you can see that the patient is not in the optimal position. Using a pillow or headrest, adjust the patient position to achieve flexion of the neck and upper cervical extension, also known as the sniffing position. This allows for proper alignment of the oral, pharyngeal, and tracheal axis to allow for air movement and a better laryngoscopic view. Before induction, you must also make sure to apply the standard monitors to ensure the patient's oxygenation, ventilation, circulation, and temperature can be continuously evaluated. These include pulse oximetry, blood pressure monitoring, 3 or 5 lead EKG, and temperature monitoring. You must also make sure you have the capability to measure end-tidal CO2 via waveform capnography. This is considered the gold standard for verification of proper endotracheal tube placement. When an endotracheal tube or laryngeal mask airway is inserted, its correct positioning must be verified by clinical assessment and by identification of carbon dioxide in the expired gas. Continual end-tidal carbon dioxide analysis is also important as it can provide detailed information on the cardiopulmonary system and the need for redosing paralytics. Once the patient has been induced, you can attempt direct laryngoscopy. With the patient properly positioned, open the patient's mouth using the scissor technique with your right hand. This is performed by flexing the thumb and middle finger past each other, with the thumb pressing on the lower teeth and the middle finger pressing on the upper teeth. Hold the laryngoscope in your left hand and insert it into the right side of the mouth. The blade is then used to sweep the tongue to the left while advancing smoothly. If a Macintosh blade is used, place the tip of the laryngoscope in the vallecula and apply tension to the hyoepiglottic ligament using a gentle lifting force, which promotes indirect elevation of the epiglottis, revealing the vocal cords. If a Miller blade is used, place the tip of the laryngoscope posterior to the epiglottis and apply gentle force to directly lift the epiglottis and reveal the vocal cords. Once the vocal cords are in view, advance the tube, watching it go through the vocal cords. Many estimate that the proper depth of is 21 centimeters in women and 23 centimeters in men, but this can vary with extremes of height. Once the anesthetist is sure that the endotracheal tube is in the trachea and the cuff has been inflated, they should connect it to the anesthesia machine circuit and mask ventilate while listening for breath sounds, watching for bilateral chest rise, watching for condensation in the endotracheal tube, and making sure there is an end-tidal CO2 waveform. Once this is confirmed, the anesthetist can secure the endotracheal tube with tape. Before attempting video laryngoscopy, it is important to manually bend your endotracheal tube to match the curve of the video laryngoscope. The GlideScope video laryngoscope also comes with rigid stylets that are recommended to be used to facilitate endotracheal tube delivery into the trachea. To perform video laryngoscopy, first place the monitor in a position where you can view it easily.
With the patient properly positioned, open the patient's mouth with the right hand using the scissor technique. With your left hand, place the laryngoscope in the center of the mouth and advance. Once the laryngoscope is past the teeth, look at the monitor to identify airway structures. Place the blade into the vallecula and gently tilt the handle to visualize the vocal cord. Next, look back at the patient's mouth and insert the endotracheal tube into the right side of the mouth while advancing it into the oropharynx. Now return your view to the monitor and slowly introduce the tube forward gently to align the tip with the glottic opening. Once aligned, advance the tube through the vocal cords under video visualization. The stylet may be withdrawn to help assist with the advancement of the tube. Once the tube has been advanced and the cuff inflated, you can confirm proper placement, followed by securing the tube. Laryngeal mask airways, or LMAs, are a type of supraglottic airway device. They may be used as a temporary method to maintain an open airway during the administration of anesthesia, or as an immediate life-saving measure in a patient with a difficult or failed airway. They are designed to be inserted blindly through the mouth and into the hypopharynx to seal around the glottic opening, allowing for ventilation. There are many types of LMAs. Here I am holding both a classic LMA that has an inflatable cuff and an iGel LMA that does not have an inflatable cuff. Often, the choice to use one or the other is simply based on the preference of the anesthetist or what is readily available. An appropriately sized LMA is generally based on patient kilogram weight. The weight range for an LMA is often printed directly on it, so make sure to check before using it on your patient. Laryngeal mask insertion is usually accomplished using the classic technique. First, you should fully deflate the cuff and generously apply a water-soluble lubricant on its posterior surface. The practitioner then inserts the LMA midline into the mouth with the posterior surface pressed flat against the palate of the mouth, and then advance with the index finger along the palatopharyngeal curve. If the LMA encounters resistance when it reaches the posterior pharyngeal wall, it is many times due to the distal tip having folded back as a result of aggressive posterior pressure, and the airway simply needs to be retracted and advanced again, applying a more upward pressure toward the top of the patient's head. If continued resistance occurs, then the operator can place the right index finger between the superior portion of the LMA and the palate and flip the tip back into normal position while advancing the device with the opposite hand. When properly placed, final resistance denotes placement of the LMA's tip in the hypopharynx, and the black line on the tubing will be even with the upper lip. The cuff is then inflated, sealing the airway over the larynx. Intracuff pressure should not exceed 60 centimeters of water pressure. Finally, the anesthetist should verify proper placement of the LMA by assessing for bilateral breath sounds, chest wall movement, and positive end tidal CO2.
Thank you for watching the video. In the next video, we're going to talk about difficult airways and some strategies to manage them. Thanks.